Yeah, so we deliver the CDC's National Diabetes Prevention Program through telehealth and live group video conferencing on Zoom with registered dietitians.
Well, hey, Lawrence, welcome to the show. How are you?
Good, thank you. How are you?
I'm doing all right. I'm looking forward to talking with you about Fruit Street and diabetes prevention and management through all that, remotely. But before we dive into, remote diabetes prevention, why don't you tell me a little bit about yourself, what brought you to what you're doing at Fruit Street, and we'll kind of dive in from there.
Yeah, well, I was planning to go to medical school when I was in college, and I had this experience where I was volunteering in an emergency room while taking a nutrition epidemiology course with a Harvard School public health professor. And I saw a very obese man come in and die from a heart attack that appeared to be related to his obesity. And I just realized at that point that a lot of um, the patients coming into the emergency room had preventable conditions related to their diet and lifestyle. So they had heart disease, stroke, diabetes, obesity, amputations, dialysis, and I just realized that we could do a lot more in our healthcare system to prevent lifestyle related disease, which ultimately led to the birth of Fruit Street as a summer project at the Harvard Innovation Lab many years ago. So
Yeah. And what
yeah,
does Fruit Street do?
yeah. So we deliver the CDC's National Diabetes Prevention Program through telehealth and live group video conferencing on Zoom with registered dietitians. The program is designed to prevent the 1 in 3 Americans with prediabetes from progressing to develop type 2 diabetes. Prediabetes just means that you have elevated blood glucose and you have a high risk
Yeah.
of developing type 2 diabetes. And the problem is that 1 in 3 Americans are pre-diabetic, but 8 out of 10 people with prediabetes don't know that they have it. So we
Oh,
first
holy
have to
smokes.
so we have to raise awareness of prediabetes and then enroll people into this program, which is based on a Medicare-funded clinical trial they did about 20 years ago, where they had 3,000 patients with prediabetes, and they compared metformin, the drug, to a placebo, to a lifestyle modification program that consisted of 22 classes with a lifestyle coach covering topics like diet, exercise, sleep, and stress management. And what they found was that the lifestyle program was more effective than metformin in preventing type 2 diabetes. The lifestyle group had a 58% risk reduction. And in patients over 60, they reduced their risk by 71%. So that was published in the New England Journal of Medicine and led to Medicare and Medicaid paying for the program, as well as employers and health plans. And then the CDC developed a national public health program where there's now 1,600 organizations delivering this evidence-based program. Most of them are in person at churches and hospitals and YMCA's.
Yeah.
We do it online through telehealth and live video chat with dietitians. The patients also get a scale and a Fitbit, and they can take
Oh,
pictures
cool.
of their food in our mobile app. So it's basically a telehealth approach to a proven intervention.
Yeah, no, that's awesome. I'm gonna pull this back a little bit because some of those statistics you threw out were pretty shocking. So, you said 1 in 3 Americans are pre-diabetic or at risk, right?
Right.
What percentage of those people end up developing type 2 diabetes? Is it the vast majority? Because, like you said, 8 out of 10 don't know that they're even on the risk factor, or like I'm assuming this is a pretty significant problem.
Yeah, well, by some estimates, it could be up to 70% of people with prediabetes could develop type 2 diabetes at some point
Oh,
in their
holy smokes.
lifetime. And I mean, these trends are getting worse, right? I mean, I saw the other day an article that said the US obesity rate is now at 44%. We could be at 1 in 2 Americans being, obese very, very soon. So it is a big problem. I mean, you don't really know when you're going to progress from prediabetes to type 2 necessarily, which is why it's important to take it seriously. You can check if you're pre-diabetic by going on fruitstreet.com and taking the CDC's 1 minute risk quiz, where it will ask you some questions. But in order to truly find out if you're pre-diabetic, you would do a hemoglobin A1C test or a
Okay.
fasting glucose test. If you had an A1C between 5.7 and 6.4, you're considered pre-diabetic, as an example. But the best way to know is by taking that blood test.
Yeah, holy smokes. So obviously, once you cross into the world of having type 2 diabetes, then you're at risk for all kinds of other health issues, right? Wounds that don't heal and amputation, all those things that you said. So in the past, and I guess um, even now, it seems like the majority of this has been managed like in person at churches, at clinics. Like, how effective has that been? And then comparing that to maybe the virtual format, have y'all noticed any difference in success rates? Is there some kind of improved access? How's that been working?
Yeah, I mean, there have been some studies done comparing in-person programs to live classes, showing that they're equally effective. So I think that's been, established. I think the big approach with, or the big benefit of telemedicine is that you make it accessible nationally, regardless of where someone lives. There's many parts of the US where there is not an in-person
Yeah.
CDC recognized diabetes prevention program. And the idea that someone's going to drive 30 minutes, 60 minutes, 2 hours to get to the local CDC recognized diabetes prevention program is not realistic. Even if you live in a city, going to the hospital, paying for parking, it's just, why would you want to do that when you could just talk to a dietitian and a group of other people from the Fruit Street mobile app or from your computer? It just makes it more convenient, and the more convenient you make a lifestyle intervention, the more likely it is
Yeah.
that someone is going to participate. Like if I do marketing to you and I say, hey, you can, click here and sign up now and do it from your home whenever you want, versus you have to come to the hospital at 1 p.m. on Wednesdays and drive and pay for parking.
Yeah.
That's
It's a
going to
bigger
change how
ask.
many people sign up. So, yeah, I think that's the biggest difference. And then obviously you get some added benefit from the fact that you can have patients step on the wireless scale every day. So we're monitoring their weight. They're taking pictures of their food in the app. And so we're seeing exactly what they're eating, giving them feedback. You have the Fitbit. So it just keeps them
Yeah.
a bit more engaged
Is all
as
that
well.
data kind of coming through the Fruit Street app? Like, is the information from their Fitbit bouncing over and they're able to review it and all of that?
Yeah, it's integrated through APIs, and the dietitian can also log in and see a list of their participants and click on a participant to see how many steps did they take that day, what was their weight, what did they eat that day, how many physical activity minutes did they log that week, and it's all uploading in real time. So in between these weekly live sessions, the dietitian can give feedback as
Yeah.
well to the participant on their diet and things like that.
Awesome. Cool
So
deal. Well,
yeah.
so it's been managed in person for a long time. We just talked about that. Now we're moving to virtual. So shifting the program into a virtual format seems like it may have come with some challenges. Were there any obstacles that you faced kind of getting the program deployed virtually? Like, how did y'all overcome it? Or has it been, have patients really, really kind of just moved into wanting to do it at their convenience online, all of that?
Yeah, I think there's different categories of challenges. One of them is reimbursement. So
Oh,
right
yeah.
now, Medicare only pays for the in-person version of the National Diabetes Prevention Program. They are temporarily paying for the virtual model for providers that were previously an in-person program.
Exactly.
So Fruit Street's still not included, unfortunately. Um, but that's just because of the public health emergency. So right now, Medicare really doesn't pay for virtual across the board. There is a piece of legislation called the Prevent Diabetes Act that, if that was passed, would have Medicare pay for virtual diabetes prevention programs, which is really necessary to make it accessible to people.
Yeah.
I mean, the idea that you would force, a 71-year-old, person in Chicago in the snow to drive to a, diabetes prevention program instead of letting them safely do it from their home is just, it doesn't make any sense, right?
Yeah.
So you have the reimbursement piece, but we've navigated that by selling to self-insured employers and health plans who can pay for kind of whatever they want in the commercial space. And also Medicaid pays for the program in some states. So we're pursuing Medicaid as well. And then there's just operational challenges. We're doing this at a pretty large scale. We've enrolled
Yeah.
more than 45,000 people. So the
Holy
scheduling is
smokes.
actually challenging. So we built this software system where like the participants could sign up and say, do they want a weekend or a weekday class? Do they want morning, afternoon, or evening sessions? And then automatically matches them to a dietitian and schedules the classes for the entire year. But if you do the math on, 45,000 people
Yeah.
multiplied by 26 sessions, you're talking about, I believe that would be millions of calendar appointments he would have had to manually create if we didn't build the scheduling automation. So that was an interesting challenge we had to overcome.
Yeah, and I'm assuming like when someone logs in or signs up, does it like do y'all work kind of cohort based? Like, okay, we've got 10 people and they're gonna all go through the sequential 20 something visits, or how are y'all managing that piece of it?
Yeah, they are cohorts, so they go through the 12-month program with the same dietitian and the same group of 30 people. So if they select Sunday classes at 2 p.m. starting on September 3rd, they would meet on Sundays at that time 26 times in a year. It's weekly in the beginning for the first 12 weeks, then bi-weekly, and then the idea is to get them to 5% weight loss by month 6, and then have monthly classes.
Okay.
So it is cohort based. If they need to switch times, they can switch to a different class. But the idea is that you build this kind of support group, and you go through the program together over the course of a
Yeah.
year.
Do the
Yeah.
participants get to interact with each other? Like, is there a forum or something like that, or are they just all they're seeing each other at the classes or at the sessions?
Yeah, well, the sessions are very interactive. The
Okay.
dietitians are supposed to be doing a very minimal amount of talking. I mean, they introduce the topic for the week. So one week it might be diet, another week exercise. So the participants are doing a lot of talking on the group calls, but there's also a group chat in the Fruit Street app and web portal where they are talking to each other throughout the week as well. And the dietitian's kind of facilitating that text chat throughout the week. So there is both synchronous and asynchronous communication between the participants as well.
Yeah, that's awesome. Well, I guess you said 45,000 people. Like, what is the I guess the engagement rate has been? It sounds like it's been really high. What about completion rates? Have y'all gotten some cohorts through? Like, how does the virtual management compare to traditional management as far as the like the outcomes, like successful completion rates of the program and the 5% weight loss and all that?
Yeah, well, the CDC runs something called the Diabetes Prevention Recognition Program that includes both in-person and digital programs. And, uh, you know, in-person and digital programs have both been proven to be able to achieve the same outcomes.
Okay.
And so the CDC, from a scientific perspective, does recognize both delivery formats as being valid. What Fruit Street does is a little bit different from our competitors is we have live classes. So we're called a distance learning program versus some of our competitors like Omada Health or Lark or Noom. They're classified as an online program, which means they have more of these like recorded
Yeah, like
pieces of
on-demand
content.
sessions or something.
Yeah, which it could be better for people that have a busy schedule. But on the other hand, Fruit Street might be better for some people. It depends on their preferences. Um, we've seen things like 1 in 3 people that attend the first class lose 5% of their weight. For example, naturally you do have a drop off in lifestyle change programs, even if it was the best in the world, because
Yeah,
it's just the nature of
it's
these
hard.
programs. So that's why we have a milestone-based payment model, which is that to say that we get paid as people progress through the program. We get a payment when they sign up, when they attend classes with the dietitian, and when they lose weight. And that makes the payers more comfortable with paying for a lifestyle intervention because they know that they're only paying for people that are actually participating in the program as well.
Yeah, no, that's awesome. How about cost savings and the like? I'm assuming maybe well, obviously for the participants, they're not having to pay for gas, pay for parking, all of that. What about on the payer side of things? Like, is there
Yep.
some sort of cost savings to be made there from the prevention program being done virtually,
Mhm.
or is it all those long tail benefits like these people potentially aren't going to get type 2
Mhm.
diabetes and all of the associated healthcare costs is going to come because of that?
Yeah, well, if someone progresses to type 2 diabetes, they would have about $9,600 of increased healthcare costs per year. And
Holy
so,
smokes. Okay.
if you only have to pay $400 for an intervention that reduces their risk by 58%, you save a lot of money. There was one study done with Medicare where for about a $500 investment, Medicare could save $2,650 within a 15-month period. So you
Oh,
can
holy
get
smokes.
the return on investment pretty quickly. But it doesn't happen. I mean, that part of it actually happens pretty quick. That's pretty quick for return on investment.
Yeah.
But for other people, it might take 5 or 10 years to see that cost savings because it's something that develops over time. Someone could be in the pre-diabetic state for 5 years before they progress to type 2 diabetes. But imagine if somebody has to get an amputation or they go on dialysis or they have a
Yeah.
stroke, it becomes quite expensive.
Yeah. Are you finding that the conversations you're having with potential client organizations like are going pretty smoothly because of that? I mean, it seems like pretty stark numbers and it's a pretty easy value proposition. Are you getting much pushback? Is there some resistance, or is it like what are those conversations looking like?
Mhm. Yeah, I mean, it depends on the employer. We've had very large customers like Walgreens and Delta Airlines as customers, and they have such big populations that they're almost more progressive, right? Because
Yeah.
they have such a big incentive financially to prevent diabetes. We also have worked with health plans like Care First, Blue Cross Blue Shield before. Um, I think that during the pandemic, actually, the employers and payers were so focused on COVID that they
Yeah.
almost it's like diabetes was not the main priority because they were in like a sense of emergency. But I think now what's happened is that the pandemic's died down and people have realized that one of the main reasons we had such a high mortality rate in the US from COVID was because of obesity and
Yeah.
diabetes.
People are
And
unhealthy.
people
Yeah.
also, yeah, and also people gained a lot of weight during the pandemic. And now we have more remote workforces. So we need solutions like telehealth to be able to manage them. So I've seen more of a shift back into a focus on wellness and prevention now that COVID has died down a bit.
Yeah.
So.
No, that's awesome. Um, anything else around about this type of program that you would want listeners to know? Like, I mean, I guess main points, takeaways, things like that.
Well, we've added some new features recently. We have an integration with LabCorp now where someone can sign up and get an
Oh,
A1C
awesome.
test when they enroll. So we're starting to recommend that we track A1C outcomes to the payers. There's another partner we've added called Modify Health, which has medically tailored meals as
Yeah.
well that are designed to improve health outcomes. That's actually reimbursed through the California Medicaid program as well. But really, it's just the biggest challenge of a product like this is sales and marketing. It makes perfect sense from a product standpoint. It's like, well, why wouldn't you want to prevent diabetes and reduce healthcare costs? But you have to get the payers, on board with it. And so there's a lot of effort being put into that by the government. We were invited to the White House Nutrition Conference they had last year, which they had for the first time in 50 years. And it was actually refreshing to see a lot of senators and government officials promoting lifestyle related interventions and really viewing it as a government problem because at the end of the day,
Yeah, it kind of
the
is.
pay, Medicare and Medicaid are paying for it. I got a cool photo with Senator Cory Booker at the conference. So he was very passionate about pre-diabetes, but I think the government's taking notice of the importance of addressing diet-related disease. It's a huge problem in the U.S. right
Yeah.
now.
Are y'all doing a lot with your own data? I talk a lot about like the value in some of these tech-driven enterprises, specifically in the healthcare space, is just the data that we've been collecting for years. Now we actually have a way to use it and to show ROI and to show the value there. Like, are y'all in the middle of not call it like peer-reviewed research, but are y'all analyzing y'all's data, trying to figure that out, and then presenting that to potential customers and payers, or what are y'all doing with all that?
We have had payers like Care First look at their claims data and show improvements in people that participate in our program. But I think one of the challenges of the digital health industry is that sometimes we have to keep reproving the same thing over and over and over.
Uh-huh.
Like I was invited by the CDC to participate in their lifestyle. I think it's called the Lifestyle Change Intervention Research Network, Lucerne, and we were just talking about it in the meeting about how we already had like a huge clinical trial done, which granted was an in-person program, but it's the same intervention, right? And so I think like it's been well established through hundreds of papers now that if we can help people live a healthier lifestyle and prevent diabetes, then it's going to save healthcare costs. But it's for some reason a bit different for payers to grasp
Yeah.
compared to like a pharmaceutical drug or a vaccine, where it's just, it's easier to maintain the fidelity of the intervention when it's a vaccine or a pharmaceutical
Yeah.
compared to a lifestyle program. So implementing these programs is a bit harder, but yeah, we have done some analysis on our product specifically, but I think it's also important to point out the mountains of data behind lifestyle intervention is really already
Exactly.
there, you
Yeah.
know.
Well, how much
So
of that too is like it, like you said, like it's easier to be like, I have this pill, and if you give your people this pill, they're gonna be fine. Versus like, we got to change the way they're exercising or eating or and all of that. It seems it's a taller lift, right?
Yeah, for sure. And I think that's why the CDC has this diabetes prevention recognition program where we have to report our outcomes data every 6 months, and we have to meet certain, standards. So I think they're trying to have that program to say to payers like, hey, these are high quality
Yeah,
programs that
they're
adhere
working.
to CDC scientific, standards as well.
Yeah. Awesome. Cool deal. Well, Lawrence, thanks so much for taking the time. If people want to learn more about you, about Fruit Street, where can they do all that? Connect with you and learn more.
Yeah. Well, you can just go to fruitstreet.com, and you can find me on LinkedIn as well, Lawrence Gerard, and happy to connect with you there. But thanks for having us on the show, and we appreciate, the work you're doing as well.
Yeah. Thank you. We'll link to all that in the show notes. So go check them out. Have a good one.
Thanks.